Thank you. Next speaker, Dr. Jagdish Dukre on a comparison of NDI capsulotomy and posterior capsule polishing in PCO management. I request the next speaker to be ready.
Good morning everybody. I will be presenting a paper on comparison of NDI laser capsulotomy and post-operative posterior capsule polishing in posterior capsule opacification. I have no financial interest. Posterior capsular opacification is the most common long-term complication of extracapsular cataract surgery. At present, the effective treatment of PCO is NDI laser capsulotomy, which involves clearing the visual axis by creating a central opening in the opacified posterior capsule. Although this procedure is easy and quick, there are complications which include increase in intraocular pressure, intraocular lens splitting, retinal detachment, cystoid macular edema, among others. The posterior capsule polishing is performed during cataract surgery to prevent or delay the formation of PCO. But here we have used it after the formation of PCO as a therapeutic measure. Many studies have been done on NDI laser capsulotomy and its complication, but no study on post-operative PCP as a treatment modality has been recorded yet. Advantages of post-operative PCP over capsulotomy include an intact posterior capsule after the procedure, minimal disturbance of vitreous, anterior and posterior segments are independent, and peripheral retinal examination can be done in a better way. Post-operative PCP was found to be effective in treatment of posterior capsule opacification and was presented in ES-CRS 4 years back. Here we have done a prospective comparative interventional study in Regional Institute of Ophthalmology, Allahabad, with the aim to compare the efficacy and safety of post-operative PCP with NDI capsulotomy for treatment of PCO. The patients with pearl type of posterior capsule opacification were included in the study. Patients with fibrotic PCO, with history of glaucoma, ocular hypertension, or loss of vision as a result of any other cause were excluded from the study. Any condition affecting the follow-up or documentation are excluded from the study. 37 eyes of 32 patients were included in the study, out of which 15 eyes were underwent post-operative PCP, while 22 eyes were subjected to NDI laser capsulotomy. Patients were followed up thereafter on post-operative first day, 1 week, 1 month, monthly thereafter for 6 months. On each visit, they were examined for visual acuity, slit line examination, and fundus examination. This is a video clip showing the procedure. Side port entry wounds are made, then bimanual irrigation aspiration cannula are introduced into the chamber. With the aspiration port, we lift the edge of the intraocular lens and go beneath it to make contact with the posterior capsule, and here there is peeling of the clumps of cells and aspiration is done to clear the visual axis. On comparison, both the groups showed significant improvement in visual acuity at end of 6 months, with around 0.5 logMAR units of improvement in both the groups. When both the groups were compared in between themselves, the visual acuity was seen to increase up till 2 weeks. Thereafter, a plateau phase was reached. The improvement in visual acuity was statistically not significant in both the groups. After 6 months of follow-up, 60% of group A patients and 54% of group B patients show 4-line improvement in visual acuity. Here we can see the post-operative PCP showing the cleared visual axis after the procedure. This is a photograph of showing a group B patient where NDI laser capsulotomy has been done. Previous authors have reported significant improvement in visual acuity after laser capsulotomy. Similar improvement was noted in our study in both the groups, and post-operative PCP was equally effective when compared to capsulotomy. Previous studies by various authors studied the complications of capsulotomy. They reported intraocular pitting, rise in intraocular pressure, retinal detachment, and cystoid macular edema as complications of capsulotomy. the expected risk of the post-operative PCP, posterior capsular rent, post-operative endophthalmitis, and IOL decentration. But no complications were seen in our study in either of the groups. Many studies have been done to confirm and estimate the increased risk of development of retinal detachment after capsulotomy. Of note, these previous studies have reported a rate of 0.82% to 4.1% of development of retinal detachment after capsulotomy. No case of retinal detachment was seen in our study. This can be attributed to the smaller sample size and shorter duration of follow-up in our study. In conclusion, our study concludes that the post-operative PCP is equally effective as compared to NDR laser capsulotomy for management of posterior capsular opacification.
Thank you very much. What type of surgery they had undergone and what type of lenses they had? These patients which you did posterior capsular polishing again, could you tell us were in the bag lenses or?
Majority of the patients had in the bag lenses.
And what type of lenses?
Foldable intraocular lens.
Hydrophilic, hydrophobic.
Hydrophobic.
And what about, did you have any patients who had these capsular additions?
We explored them from this.
The question that hydrophilic or hydrophobic lens, because in most of the hydrophobic IOLs, it is very difficult to go behind the IOL because the adhesion is so strong with the anterior capsule. It's really not possible to go and then peel off the simples. That's the reason.
That is why the incidence of PCO is less in hydrophobic.
Most of them don't have hydrophobic because they stick to the posterior capsule, and for you to go and wash there again is a bit of a problem.
So what is the take-home message?
Sir, basically this can be used as an alternative treatment modality for patients who are at a greater risk of complications from NDR laser capsulotomy. Basically, patients with longer axial length, that is myopic patients who are at a greater risk of retinal detachment, here this method can provide them a better treatment modalities.
Definitely, because you have to go intraocular for doing polishing, so that becoming intraocular procedure. So it cannot be indicated for all
patients. Not a standard.
I have a very strong observation on the informed consent and ethical part of the study. I hope it has been conveyed to the patient that you have a two option, one no surgery with laser and other with the surgery.
Yes, sir.
And most of the institution will not accept this as a ethical clearance because a gag capsulotomy is time tested all over the world. Polishing is not a standard procedure.
There are many things that come up first.
No, I understand. Like in 1990, sir, I was using a needle, pars plana, to make the capsulotomy. But in the present era, I am a member of the National Ethical Registry Board. And this type of study we are not going to accept.
Why are you giving intravitreal injection? Why don't you?
No, intravitreal you don't have the option of laser.
First thing is, you see how was it started?
This study is highly unethical. I want to see the informed consent. Whether it was taken or not.
Doing intravitreal injection,
you cannot say that it is unethical because
sir, if I have an option,
you have the option, then it's okay. But doing the capsulotomy in a high myopic,
I have not seen any detachment so far in 30 years.
They are the different person doing the capsulotomy on the same time. Then if you require your capsulotomy,
I have put up my views. Whether it is accepted is different, but ethically this study is not correct.
No, you cannot say that ethically.
No, you
cannot
say that.
Then you stop doing all studies.
We will refer it to the our Ministry of Health. I will refer it.
No, sir, the issue is myopes. No, myopes are
doing all
myopes are prone for
everything will come to sin state. They will never answer it.
Now, all
government clearance at every level is too much.
Nowadays, any study of this nature needs a national registry clearance. This has come since the last year,
gone from
2013 onward.
So what about giving
This is
intracameral
an accepted
moxie? It
mode
is
of-
well established fact
This is an
that there is
accepted
no
mode.
need of
This is
giving
nothing
any.
new, which is you have to go to the
I
government
agree.
for clearance.
Agree. Accepted mode is couching in 1760, not today.
After couching came the intracapsular cataract extraction.
I strongly disagree.
While couching has
Sir,
been-
I
in situation where they cannot do it.
I go.
In those also we are doing this.
And sir, for your information, in this issue of Indian Journal of Ophthalmology, this article has been published.
Publishing is a different thing.
This has been published.
I am now telling you the present era. Whatever you have done is done.
So it is not
If
unethical.
you
In situations where it is indicated, it should be done. Otherwise, the capsular is a better option. That is a clear message.
Then
So
you don't
children
do
may
any
always
research.
do capsular.
Stop
you
doing
you
research.
stop doing the capsulotomy and start practicing in your institution all polishing.
No, we are saying where it is indicated, like iris cases in general, that is a accepted thing to do.
Anyhow, I want to convey to the house that this procedure is not the first option and should not be taken as a home method.
Okay, that time is short.
No, I have, because it has a strong ethical. I have not raised my voice. Since I am the part of the registry system, that is why I am giving warning to the ophthalmologists
That is correct.
that this is something very, very serious issue to consider for future.
Why are you giving moxie injection intracameral?
I am not giving.
No, the study was there.
No, it's
There
all
are so
right.
many studies, new studies are coming in the world today.
Thank you, sir. I think we are running out of time. Thank you very much. We'll keep discussing these things in years to come. Now, I request the next speaker, Dr. Varun. He'll be talking on contrast sensitivity and total post-op spherical aberrations in multifocal IOL.
Good morning, everybody, members of the chair, the audience. I'm Dr. Varun from Narayan Nethralaya, Bangalore. I'll be speaking about the relationship of VF14 questionnaire scores with contrast sensitivity and total post-op spherical aberrations in patients implanted with bilateral multifocal aspheric IOLs. We have no financial disclosure. Spherical aberrations have a very strong influence on the image quality. This has been proved in literature. But the contribution of essays to enhancing the quality of vision after cataract has been a matter of debate. There is a group which agrees that multifocal effect of low-level essays increases the depth of focus, whereas some others believe that the total correction of essays may improve the patient's quality of vision at the best focal position. The aim of our study was to measure the Visual Function Index 14 quality of life questionnaire scores in patients implanted with diffractive aspheric multifocal IOLs in both the eyes. We correlated these scores with subjective measurement of photopic contrast sensitivity and objective aberrometric findings of TPO assays or total post-operative spherical aberrations. 32 eyes of 16 patients without any ocular comorbid conditions who underwent uncomplicated bilateral cataract surgery with diffractive aspheric multifocal IOLs were included. Vision, photopic contrast sensitivity and TPO assay by ray tracing aberrometry, eye trace, were tested at the final post-op visit at 6 weeks. This was the main tool of the study. It's the VF14 QOL questionnaire. It was basically originally designed to assess functional impairment in cataract patients. It has got adequate psychometric properties, has a concise format, it's easy to administer, and has been validated internationally. On the basis of the scores of the patients, we divided them into two groups. A high scoring group which scored 95 and above, and a low scoring group which scored below 95. Vision, contrast sensitivity, and the spherical aberrations were compared for both these groups. The analysis that we did was Kolmogorov-Smirnov test was applied for the normalcy of data to test whether the data was normal or not normal. Thereafter, the normally distributed data was compared using t-test, student t-test, and the non-normally distributed data was compared using Mann-Whitney u-test. P-value of 0.05 was taken as significant. The result, mean age of the patients was 63 years. 20 eyes scored 95 and above and were included in the high scoring group. 12 scored below 95 and were included in the low scoring group. The vision in both groups, BCVA was 20/20 N6 for all patients, so no difference as well as far as Snellen's equity was concerned. Photopic contrast sensitivity at 3, 6, 12 and 18 cycles per degree did not show any significant difference between the two groups. However, we did find a significant difference in the spherical aberrations of the two groups. The high scoring group had TPO assays approaching 0, minus 0.0075 microns, whereas the low scoring group had their spherical aberrations towards the positive side, plus 0.0251. Coming to the discussion, Literature reveals that some amount of positive spherical aberrations are good for improving the quality of vision. Yannick et al. Showed that for the best visual quality, the amount of TPO-SA should be between 0.07 to 0.1 micron. They concluded that for the best contrast sensitivity, which they measured using MTF values, SAs should be closer to 0, whereas for the best depth of focus, which they measured using the Stahls ratio, certain amount of positive SAs should be present. That is why they reached the value of 0.07 to 0.1, which was a compromise between the two. Their study included objective testing based on the OCAS, or the Optical Quality Analysis System. Our study is similar to theirs. However, instead of testing objectively, we validated our results with subjective testing. And in our study, we found that functionally, objectively, the patients who scored highest were the ones with TPOSs approaching to 0. So in conclusion, I would like to say that objectively, both depth of focus and contrast sensitivity play a very important role in improving the quality of vision. Hence, there has to be a certain level of positive SAs post-cataract surgery. However, in our study, we found that functionally and subjectively, patients with near 0 SAs had statistically higher scores than the other group. So perhaps functionally achieving 0 post-operative spherical aberrations might give better patient satisfaction levels at cataract surgery. Thank you.
Thank you. Thank you. Any question? Any suggestion? Dr. Ramesh, probably.
You have this, whenever you did the measurement, you have taken a calculation, the importance of the pupil size when you did this.
Yes, sir. We did it in the photopic conditions because we wanted
What
to...
was the size of the pupil?
Size was the physiological pupil, photopic pupil for the particular patient. Because the patient...
But what was the, because...
We did not measure, we did not do a measurement.
So that is another thing which is very important.
Exactly.
Because each patient behaves differently. So
If you allow me to answer, sir, we did address this issue when we were starting the study. But the study is questionnaire-based, subjective quality of life. So the patient will tell you the quality of life at whatever pupil size the patient has, which is the pupil size in which we are measuring contrast sensitivity, which is the pupil size we are mentioning in spherical aberration. So for a patient, the pupil size is constant, which is photopic condition for ray tracing, your contrast sensitivity, as well as the questionnaire. We did not generalize. We could have got that higher pupil size patients have more aberrations and lower. Definitely true. But in this study,
the most important factor, which is ultimately you have to find out. And
exactly.
The second thing is, when you are measuring with all these machines, you have to take into account the rexis size.
Exactly. Yes.
Because the rexis size is approximately 5 millimeters. And none of these machines take into account of the aberrations created by the rexis
margin. Yes, definitely.
And that is why all these machines which are evaluating your inside multifocal or monofocal eyelid for whatever quality of vision is not as accurate when we do it in vitro.
Exactly. Point taken. Thank you.
Thank you. For conducting the session, and thanks to the audience. We're just calculating the marks, and meanwhile, next session, chairman and speakers are here. They can take that.
Few papers in this session, and may I request who are the people who are going to presenting these papers in this session? Please come forward. All the presenters, please come forward in the front row. The first paper is Dr. Varun Kharbanda. Are you ready? Yes, sir. Please come. And after this, we have Dr. Sunil Jain. Dr. Sunil Jain? Yes. You are there? And then we have Dr. Santosh Krishna. Dr. Santosh Krishna? Yes. You are there? Then Dr. Rohit Kapoor. Dr. Rohit Kapoor. कहाँ है रोहित कपूर भैया? ये तो आगरा के हैं? अच्छा नहीं मेरठ के हैं इनको वहाँ अवार्ड मिला था चलो डॉक्टर प्रदेश मेहता डॉक्टर सुहास हल्दीपुरकर representing Dr. Rujita please then we have Parikshit Gogate it's Gogate then the next one is Dr. Neeraj Agarwal. Very few speakers are there. Thanks, God. And Dr. Ashwini Kumar from Patna. Dr. Ashwini Kumar. Then we have Dr. Shroff. Dr. Shroff, only they have written Ashok Praniji Vandas. No. So I'll request Dr. Karmancha to present.
Good morning, everybody. Back again. I'll be talking this time about the visual function and quality of life with different degrees of pseudophakic monovision in patients with bilateral cataract surgery. We have no financial disclosures to make. Achieving spectacle-free distance and near vision after cataract surgery is one of the biggest challenges of ophthalmology. The option at present is to provide the visual system with two simultaneous images, either monoocularly using multifocal IOLs or binocularly through monovision. Our study deals with the satisfaction level in patients post-cataract surgery with monovision. The aim of this study was to assess visual outcomes and patient satisfaction levels in post-cataract patients with various degrees of pseudophakic monovision. The inclusion criteria, 56 eyes of 28 patients were included in the study. Patients with uneventful cataract surgery in the first eye who had an unaided visual acuity of 20/30 or better, without any ocular comorbid conditions, and good visual potential in the phakic eye. Also, only those patients were taken who were willing to go ahead with monovision after proper counseling. Patients selected were made myopic in the second eye based on their perceived needs, whether they wanted to do more of near work or they were more habitual of doing intermediate work. Accordingly, the patients were divided into two groups. The mild monovision, who were targeted a monovision of myopia of 0.5 to 1.5 in the second eye, and moderate monovision with a targeted myopia of 1.5 to 2.5 in the second eye. All surgeries were done by the same surgeon with the same technique, phacoemulsification with a 2.8 clear corneal temporal incision, and foldable acrylic IOLs were implanted, and all were uneventful. Post-op final refraction was done at 6 weeks. Also, at the same visit, the patients were requested to answer the VF14 QOL questionnaire. Like I just mentioned, this questionnaire was developed to assess the functional impairment of cataract patients. It possesses adequate psychometric properties, has concise format, it's easy to administer, and has been validated internationally. Post-operatively, patients were divided into three groups based on the spectacle acceptance at 6 weeks. First was the mild monovision with 0.5 to 1.5 diopter myopia. Moderate monovision, which had a myopia of 1.75 to 2.5 diopters, and a high monovision, which had a myopia of greater than 2.5. These patients essentially were the refractive surprises. VF14 scores for patients in all the three groups were analyzed. We used the Kruskal-Wallis test to test for difference between the mean of the three groups, as the data was not normally distributed. We then used repeated Wilcoxon rank sum test with Bonferroni's correction for post-hoc testing. Here the significant p-value was 0.0125, not 0.05 because we were comparing three groups here. Results, the mean age of the patients was 59 years. BCD, best corrected distance vision for all patients was better than or equal to 20/30. Best corrected near vision was better than equal to N8. Mean scores of the mild monovision group was 94.11. The moderate monovision group was 97.62, and the high monovision group was 96.58. These values did not have any statistically significant difference between them. The p-value is 0.035. Satisfaction levels with monovision have been well documented in literature. Previous studies have mentioned various degrees of monovision, from 1 to 1.5 to even up to 2.75. We decided to take it a step further and give patients different levels of monovision depending on their perceived needs. Patients whose lifestyle required more of intermediate work like computer, TV watching, etc. were given mild monovision. Patients who required more of near work like reading, writing or fine work were given moderate monovision. High monovision essentially was a group of patients from the moderate monovision groups who ended up with overcorrection and as such were refractive surprises. While considering, in conclusion, we would like to say, while considering patients for monovision, targeting a post-op myopia of 1.5 to 2.5 would give the most satisfactory outcome. Although the difference was not statistically significant, the patients with moderate monovision clearly scored higher than both the other groups. Also, the degree of monovision can be individualized based on the needs of every patient, as patients in all three groups achieved very high QOL scores. Thank you.
Thank you. Do you have any announcements?
I have to announce the result of the last CATEX session 2. The paper grade maximum number is the best paper of that session was comparison of optical quality of Picky Beck multifocal IOL with that of primary multifocal IOL. Dr. Soumya Manish.
Dr. Sunil Jain, here, the next speaker.
Thank you. Good morning to the respected chairman, co-chairman, convener and moderator, and a very good morning to the audience, my fellow colleagues and seniors in the audience. This is a presentation from Indira Gandhi Eye Hospital and Research Center, Lucknow, UP. Is retinal acuity meter a valuable predictor of post-operative visual acuity in cataract patients? There is no financial interest in this presentation. The RAM technology is a combination of three basic optical principles: small aperture pinhole, correct visual angle, and bright illumination. The small aperture pinhole places the eye in almost universal focus, and near correction is added to maximize resolution. The letters at 40 centimeters subtend the same visual angle as Snellen letters at 20 feet, and the bright illumination compensates for the reduced illumination by the small aperture pinhole and the media opacity. This device is battery operated and portable. The retinal acuity meter combines these three principles into an uncomplicated calibrated system that accurately measures retinal acuity in eyes with clear lenses, cataracts, PCO, maculopathy and glaucomatous field loss. Our study was a retrospective single center study in 43 eyes of 40 patients. Study period was November 2012 till April 2013. The usual procedure in our hospital, we used lambda 100 from Hine, which has 6 increments from 20/300 to 20/25. The testing was performed by the same technician to reduce error. Testing time was approximately 1 to 2 minutes. Cataract grade, presence of associated eye disease, and post-operative visual acuity were also recorded. 82 patients underwent RAM acuity testing. 42 patients were either not advised surgery or did not undergo surgery until the start of the study. Age ranged from 17 to 75 years. 20 were males and 20 females. The pre-operative RAM acuity was 612 part to 66 in 81.40% eyes and 636 to 618 in 18.60% eyes. The same percentage distribution is shown in tabular form. Now, what was the outcome? The post-operative best corrected visual acuity was 612 to 66 in 86.05% eyes, 636 to 618 in 6.98% eyes, and 1/60 to 5/60 in 6.98% eyes. 65.12% patients had 6/6 vision, 16.28 had 6/9, 4.65 6/12, 4.65 6/24, 2.33 6/36, 4.65 4/60, and 2.33% had 3/60 vision. Reasons for best corrected visual acuity being lower than predicted in 5 patients. One patient had optic pallor, which was detected 1 month post-operatively. Second patient developed viral corneal ulcer, which was under treatment, but he was lost to follow-up after 1 month. The third patient had a pre-existing adherent glaucoma, and the fourth a pre-existing corneal degeneration, but there was only half-line drop in predicted best corrected visual acuity. Fifth patient had a nebular corneal opacity, developed SPKs, was under treatment, but was lost to follow-up after 1 month. Discussion. As you know, RAM has been clinically tested for over 10 years, and earlier models of this technology were the illuminated near card and a smaller version, the mini INC. The RAM has retained the critical testing parameters of the INC and mini INC, namely identical letter size and brightness, so that all research data obtained with these instruments are applicable to the RAM. RAM has following advancements: an ergonomic molded faceplate, an improved disc rotating mechanism, high resolution digital photographic lettering, and clearly visible indices. Interferometer and potential acuity meter are other methods of predicting visual acuity after cataract surgery. A study by Sage et al. Concluded that 3-degree interferometry gave more accurate results than 8-degree interferometry and the PAM. And RAM is a lot easier to use than PAM, which is very cumbersome, according to random survey of RAM user base. So the conclusion of a study, it clearly indicates that RAM is a valuable predictor of post-operative visual acuity in cataract patients. And as you must have noticed in the table, 3 cases with pre-existing corneal pathology in our study did not achieve the predicted visual acuity. What is the take-home message? RAM testing should be part of pre-operative cataract surgery protocol for cases of retinal macular disease in which we do not expect BCVA to be 6/6 or optimum. It should be adopted by all centers as it is inexpensive, reliable, easy for patients and technicians, quick, accurate, provides repeatable results and realistic expectations, prevents surgical delays and unexpected poor outcomes, prevents unnecessary surgeries, and is portable. These are the references. The first 2 were published in the Journal of Cataract and Refractive Surgery, the one by Lee Sage in 2002 and the next in 2012. I dedicate this presentation to my beloved parents, Dr. Brijendra J. Jain, who unfortunately passed away for the heavenly abode in April 2013, and my mother, who is a gynecologist, Dr. Lakshmi Jain. This is the Deputy CMO and CMO of our hospital, the team, some of my colleagues in the hospital, our team of optometrists, and the front view of our hospital. We end with a few words of wisdom, that you certainly have the right for prescribed activities, but never at any time in their results. We sincerely thank the Chairman Scientific Committee, the local organizing committee, and the respected panel, the Chairman, Co-Chairman, Convener and Moderator, for giving us the opportunity to present this paper at the prestigious AIOC 2014 Agra. Thank you. I thank you very much for patient hearing.
Santosh, but I would like to give this message to the audience that you should not unnecessarily put these photographs. You should stick to your scientific work that you have done, because this is a competition, and here the scientific work is important rather than projecting your hospital or other Bhagavad Gita or Ramayana or Quran. Okay?
Now I call upon the next speaker, Dr. Santosh. Please come and present the paper.
The left is speaking. Next, HDO must be prepared.
Very good morning to all of you. The topic of my presentation is outcome in patient with high corneal astigmatism using toric intraocular lens. We have no financial interest. The advent of toric IOL led to more predictable and accurate correction of astigmatism and has now become procedure of choice. The accuracy of toric IOL is one of the most commonly used among this category in cataract surgery. High astigmatism can be inherent or secondary like post-trabeculectomy surgery, pterygium excision or corneal trauma. The prevalence of high astigmatism of more than 4 diopter in patients presenting for cataract surgery is very low, and there are no studies showing use of accuracy of toric IOL in these group of patients of high corneal astigmatism. Our aim of study is to analyze the combination of highest available accuracy of toric IOL and steep axis incision in reducing the residual astigmatism and improving uncorrected visual acuity. Ours is a retrospective single-center study done at Shankar Nethralaya. Enrolled eyes having cataracts and high irregular corneal astigmatism due to trauma, trabeculectomy surgery, pterygium excision, and pre-existing corneal astigmatism more than 4 diopter. All patients underwent comprehensive eye examination including visual acuity, slit lamp examination, intraocular pressure, and fundus evaluation. Corneal topography was used to assess the axis of corneal astigmatism. Axial length of the intraocular lens was determined by, and axial length of the eyeball was determined using A-scan biometry. The spherical power of the IOL was determined SRKT formula, and cylindrical power and axis of toric IOL determined online calculator provided by the IOL manufacturer. Standard corneal surface marking were done before surgery in all patients at 0, 180 and 270 degree. The same surgeon performed all the surgeries using topical anesthesia, standard phacoemulsification technique with 2.8 mm incision at steep axis, and use of accuracy of toric IOL of T9 series used in all patients. Post-operatively, all patients received prednisolone acetate 1% eye drop 6 times daily, tapered over 5 weeks, and ciprofloxacin 0.3% eye drop 4 times daily for 1 week. Post-operatively, the patients were examined on day 1, day 4, 3rd week, and 6 months. Patients were evaluated for uncorrected distance visual acuity, residual astigmatism, and the orientation of the toric IOL axis was determined at the slit lamp examination. All data were collected in Excel database and analyzed using SPSS for window. The arrow in this picture clearly shows the axis of the toric IOL marker being placed in the post-trabeculectomy patient. You can see the limb of the post-trabeculectomy surgery. This is the pre-op topography of the corneal tear repair patient, and this is the post-op picture taken 3 months after. The arrow clearly showing the axis of the toric IOL, and you can well see the scar of the corneal tear repair. This is the pre-op topography of the pterygium excision patient, and this is the post-op picture of the same patient, clearly showing the pterygium excision scar. Now coming to the result, our study included 9 eyes of 8 patients of mean age 54 years, and mean follow-up period was around 9 months. Uncorrected distance visual acuity was 6 by 12 or better is achieved in 8 out of 9 eyes. Kindly notice pre-operatively mean cylinder power was minus 5.26, which came down to minus 1.11 diopter. Toric IOL showed excellent rotational stability with 8 out of 9 eyes had less than 5 degree off-axis rotation. This table shows the data of all 9 patients included in the study. The green segment of the cataract patients have high primary corneal astigmatism, whereas the red segment of cataract patients have high secondary corneal astigmatism like trabeculectomy surgery, pterygium excision, and corneal tear repair. All these patients received T9 series of accuracy of toric IOL with very nice post-operative outcome. There are various modes of reducing astigmatism during cataract surgery like limbal relaxing incision.
Where is the technician, please?
In every hall this time video wala is a big problem. Every hall.
Nobody is there.
They are there, but
cataract surgery like liver relaxing incision, opposite clear corneal incision, and astigmatic keratotomy. But the result of these methods are less predictable and stable as compared to the toric intraocular lens. Keratometry is unable to give reliable readings in distorted corneas, so placido-based corneal topography was used in getting more accurate values for magnitude and axis of astigmatism in our study. The simulated keratometer reading and axis of astigmatism derived from it was used for calculation of toric intraocular lens. This is a this is a comparative study between ours and AIOC et al., and the study is well comparative. In our series, we found that axis of toric IOL predictably reduces refractive astigmatism with cylinder correction. Lens had excellent rotational stability with 8 out of 9 eyes maintaining axis within 5 degrees of original axis till the last follow-up, which was at around 6 months after surgery. So in conclusion, we can say that a cataract patient with high regular corneal astigmatism, inherent or secondary, a combination of toric IOL and steep axis incision significantly reduces astigmatism and improves uncorrected distance visual acuity. Thank you very much for your kind attention.
Thank you, Dr. Santosh. What new you want to add, what is already existing in the literature?
So since now the toric IOL is used in between 2.5 to 4 diopter, in our study, our group of patients, the range of cataract was between 4 to 6.5 diopter. Okay. And till now, the toric IOL has been used in inherent primary corneal astigmatism, whereas in our study, we have also included secondary causes of astigmatism like post-trabeculectomy surgery, post-pterygium excision surgery, corneal tear repair patients. But the limitation is that those patients should have regular corneal astigmatism. So in our study, the range of astigmatism is very high, that is from 4 to 6.5 diopter, and we also included secondary corneal astigmatism.
Thank you.
Thank you, sir.
Dr. Kapoor.
Good morning, everybody. I am Dr. Rohit Kapoor. My topic is correction of preoperative astigmatism by on-axis clear corneal incisions in phacoemulsification. The two main determinants of refractive state of eye following phacoemulsification are IOL bar and surgically induced astigmatism. Factors such as wound location and architecture are important predictors of surgically induced astigmatism. Superior and nasal locations induce greater refractive changes than temporal corneal incisions. This effect can be intentionally used by the surgeon to reduce or treat pre-existing astigmatism. This study compares the short and intermediate term astigmatic outcomes of temporal versus superior clear corneal on-axis phacoemulsification incisions. Aim of the study was to determine the amount of correction of preoperative astigmatism by on-axis clear corneal incisions in phacoemulsification. 60 cases underwent planned phacoemulsification and were randomized into two groups of 30 each. Group A comprised of 30 patients with the rule astigmatism scheduled for phacoemulsification with foldable IOL with a superior incision, and Group B comprised of 30 patients with against the rule astigmatism scheduled for phacoemulsification with foldable IOL with a temporal incision. Patients with astigmatism up to 1 diopters were included in the study, whereas patients with previous ocular surgery, presence of corneal pathology, pseudoexfoliation, and astigmatism exceeding 1 diopters were excluded from the study. Based on the axis of cylindrical component of refractive error, according to keratometric reading, superior temporal corneal incisions were constructed. Post-operative examinations were conducted at 7, 28 days, and 6 months. Uncorrected visual acuity and best corrected visual acuity were measured, and keratometry was performed at each follow-up visit. This is a graph showing surgically induced astigmatism, and as it is shown, the surgically induced astigmatism was significantly higher in superior incisions than temporal incisions. Mean preoperative keratometric astigmatism was 0.8 diopters in the superior and 0.68 diopters in the temporal group. Mean SIA at 1 week and 4 weeks was 0.96 versus 0.75 diopters, and 0.83 diopters versus 0.69 diopters in the superior versus temporal groups respectively. Mean surgically induced astigmatism at 6 months post-operatively was 0.73 diopters versus 0.51 diopters in the superior versus temporal groups respectively. In both groups, the amount of SIA at 6 months was much lower than the initial visit, and mean keratometric astigmatism, that is the residual astigmatism at 6 months post-operatively, was only 0.07 diopters and 0.17 diopters. Mean SIA at 6 months post-operatively was 0.73 diopters versus 0.51 in the superior versus temporal groups respectively. Despite the significant differences in keratometric and surgically induced astigmatism, BCVA was comparable in both the study groups. Patients undergoing cataract surgery expect clear vision and less dependence on spectacles. The simplicity and usefulness of clear corneal on-axis incisions cannot be assessed without considering other options of astigmatic correction in cataract surgery, like astigmatic keratotomy, which has the disadvantages of glare incisions, diplopia, and also require the use of diamond knife. Relaxing incisions also require a use of diamond knife, and toric IOLs are expensive, implantation requires additional skills, and there is always a risk of post-operative rotation. Excimer laser ablation is also expensive, and also flap-related complications are present. In conclusion, employing this technique does not require additional instruments and therefore can be performed without altering surgical settings. To summarize, in eyes with mild to moderate astigmatism, on-axis clear corneal incisions, phacoemulsification led to partial to complete correction. Hence, it can be utilized as a simple tool to correct mild to moderate astigmatism and also provides excellent uncorrected visual acuity. Thank you.
Thank you, Dr. Rohit. Now I call upon Dr. Prathamesh Mehta. Prathamesh Mehta.
Good morning, respected chairman, co-chairman, convener and moderator.
The next speaker is Dr. Rujita. Are you ready?
So I have no financial interest in any subject matter of this presentation. The purpose of this study is to report a series of cases with only a posterior liquefied cortical layer causing sudden visual decline. The study was conducted at Arvind Eye Hospital and Postgraduate Institute of Ophthalmology, Pondicherry, where all the patients presenting with complaints of sudden visual decline were taken into consideration. It's a prospective case series where patient demographics, detailed clinical history, and best corrected vision were noted. Detailed slit lamp anti and posterior segment evaluation, Visante anterior segment OCT, and ultrasonography was done. The results showed there were 9 eyes of 9 patients. The male is to female ratio was 5:4. Right eye is to left eye was 6:3. Mean age was 55.22 years from a range of 39 to 63 years. Mean duration of reported visual decline by the patients was 3.11 days, ranging from 1 to 7 days. Range of the best corrected vision at the time of presentation was half by 60 to 6 by 18 on the Snellen's chart. 55.55% were diabetes. And only one of them had uncontrolled diabetes at the time of presentation. The type of cataract in the study all eye showed cortical cataract with a layer of opalescent liquid in the posterior subcapsular area with a nucleosclerosis ranging from grade 1 to 3. The contralateral eye had 7 eyes with cortical cataract with nucleosclerosis of the grade 1 to 2. In addition, one eye had a posterior subcapsular cataract. You can see the imaging. This image on a diffuse illumination shows intumescent mature cataract, but on a slit imaging, we can see that it's not such an advanced cataract. The cortex is relatively clear, but there's a opalescent layer on the posterior aspect. On the retro illumination, we can see the cortical opacities. So we went ahead and did an anterior segment OCT imaging, which showed a hyperdense effect between the posterior edge of the nucleus and the posterior capsule, whereas the other eye didn't have any such opacities. And the ultrasound B scan showed 2 hyperreflective echos at the posterior capsular area with a clear area in between. So all of them underwent cataract surgery by phacoemulsification. During surgery, there was a slightly raised intralenticular pressure. Before doing hydrodissection and tapping the nucleus, there was some amount of turbid fluid that was seen escaping. Post-operatively, the IOL was in the bag with clear posterior and vitreous phase, posterior capsule and vitreous phase. This is the post-op image which shows a clear capsule and clear vitreous phase, and the other eye imaging showing a cortical cataract. So usually sudden painless visual decline is associated with sight-threatening conditions such as vein or artery occlusion, but in case of cataracts it is associated with diabetes. We went through literature to find out what is the reason for this, because the relative risk of cortical cataract to diabetes was 1.8:1. So we could not find any good literature in this. So we went ahead we went and searched in the pathology books, and we could find some cortical degeneration is marked by clefts and spaces in the cortex filled with liquefied cortical material which oozes from the fractured lens fibers. And we also know that the cortex is the one which gets liquefied in Morganian cataract. So we just hypothesized that probably this is one of the presentation in the spectrum of cortical cataract. So in conclusion, liquefaction of cortical cataract can be a cause of sudden visual decline, and detailed clinical evaluation and adjoint test can help in diagnosing such entity and managing it appropriately, because most of these cases were referred to us as endogenous endophthalmitis or vitritis or uveitis. So doing a detailed examination can save the anxiety of the patient and your anxiety also. Thank you so much.
Apart from the diabetes, do you find any other cause?
We tried to search for posterior subcapsular because that's also associated, but there was only one patient who had posterior subcapsular cataract in the contralateral eye, and because of the liquefaction we could not find any on the study eye. We checked for any systemic illness, any drug allergy, any association of an area, but nothing was common other than the cortical cataract. Our only closest competitor with the cortical cataract was diabetes, but that was also in only 55.55, and only one patient had uncontrolled, the rest all of them had a controlled diabetes.
So more investigations are required.
More are required, means more details. Thank you so much, sir.
Thank you.
The next speaker I call upon Dr. Ruchita.
Thank you, sir.
On behalf of the Suhas Hospital.
Good morning to all the judges and my colleagues. Today I am here to present my study on the effect of phacoemulsification cataract surgery on corneal astigmatic axis. Astigmatism following cataract surgery consists of two components: preoperative astigmatism, which is intrinsic to the patient, and surgically induced astigmatism, which is a result of the procedure. Any procedure that alters the patient's intrinsic astigmatism causes SIA. The factors affecting SIA, as we know, include the size of the incision, site of the incision, configuration, pre-existing astigmatism, and the patient's age. Therefore, calculating SIA should ideally control for all these sources of variability. Although there have been a lot of studies about the amount or magnitude of the induced post-operative astigmatism, there is no study, to the best of our knowledge, which looks at the behavior of the corneal cylindrical axis in phacoemulsification cataract surgery. So, in this study, we have assessed the amount of surgically induced astigmatism caused by clear corneal incisions of 2.8 mm and 2.2 mm in size, as well as the shift in preoperative corneal astigmatic axis after phacoemulsification cataract surgery. This was a secondary data analysis conducted at Lakshmi Eye Institute, Panvel, which is a tertiary eye care center. It included 62 eyes of 47 patients. These were patients who underwent uneventful phacoemulsification cataract surgery with implantation of a standard foldable IOL and having a pre-operative cylinder of less than 1.5 diopters. The data analyzed were pre- and post-operative autokeratometric values for calculation of the SIA and shift in corneal astigmatic axis after surgery. Coming to the results, we had 62 eyes, out of which 21 had a 2.8 mm incision and 41 had a 2.2 mm incision. Now looking at the second table, we see that more of against the rule group, more eyes had a clockwise rotation of the axis, where more of anti-clockwise rotation of the pre-operative cylindrical axis was seen in oblique astigmatism. The mean absolute rotation of axis was seen maximum in against the rule astigmatism and minimum in with the rule astigmatism. The mean astigmatic axis shift in preoperative cylinder of more than 0.75 diopters was 53.9 degrees, which was more, and in preoperative cylinder of less than 0.75 diopters was 35.6 degrees. The mean absolute rotation in on-axis incisions, that is when the cylindrical axis was within 10 degrees of the incision site, was less, that is 22 degrees, than all the other incisions. Now this is a graph which is showing the correlation of the angular distance between the incision and steep axis, which we have called the difference. It is plotted on the x-axis, and the absolute rotation of the axis in degrees plotted on the y-axis. The grey shaded area is the 95% confidence interval, and the almost flat line indicates that there was no correlation between the two entities. We also calculated the surgically induced astigmatism, which was around 0.5 to 0.6 in all types of preoperative astigmatism. This is another graph which is showing the correlation of the angular distance between incision and steep axis, which we have called the difference, and the surgically induced astigmatism in diopters plotted on the y-axis. Again, a flat line is showing that there was no correlation seen. On regression analysis, we found an interesting result that for every 0.01 diopter increase in the SIA, there was a 1 degree increase in absolute rotation of the astigmatic axis. There were a few limitations of this study which we would like to work upon in future. Inadequate sample size in the group with 2.8 mm incision as compared with the 2.2 mm incision, and less number of patients in group with the on-axis incisions. We came to our conclusions that if the surgical incision is not placed on the steep axis, the astigmatic axis shift is unpredictable. 2.8 and 2.2 mm temporal clear corneal incisions are not totally astigmatism neutral. Hence, it would be better to either place the incision on the steep axis or take an incisor smaller than 2.2 mm to get a more predictable refractive outcome. These are my references. Thank you for your patient listening.
Use auto tiltometer for pre-operative
Yes, sir.
astigmatism.
Yes, sir.
But it will give the astigmatism of both corneal and lens both. I think should use tiltometer.
Okay, sir.
Now I invite Dr. Gupte.
Respected Professor Satsangi, Professor Gupta, Professor Kamaljeet Singh, Dr. Singh sir, and distinguished audience, Malik sir. So I'm going to present a small comparison, a small study comparing the contrast sensitivity between monofocal and multifocal IOLs after phaco, and is there really a difference? We of course know that monofocal IOLs have a single power, while multifocal IOLs have optics to focus for distance as well as intermediate and near vision. I'll not go into the details of the types of the refractive optics or the diffractive optics of the multifocal lenses. We know that multifocal IOLs have the advantage to reduce spectacle dependency over monofocal IOLs. But then they say multifocal IOLs have one disadvantage, that they may reduce contrast sensitivity, and this results in loss of sharpness of vision, particularly under poor visibility conditions such as low light or fog, which mercifully is rare in India. So the aim of our study was to assess and compare the contrast sensitivity between monofocal and multifocal IOLs after phaco. This was a comparative clinic-based study done in my small private practice setting over 6 months, and we had taken 50 patients. And this was the usual instrumentation. We had used an immersion gaze scan and of course an inflammation tonometry. The contrast sensitivity was using a Perry-Robson chart. And this is a flow chart of how the patients went through, and the contrast sensitivity was finally taken after 3 months. The Perry-Robson chart is a large chart hung from a wall at 1 meter from the patient's eye. We keep it covered so that sunlight should not damage the contrast. And the test therefore uses the 26 APC method with 3 decisions at each contrast level. And the luminance of the white areas in between the acceptable range of 60 to 120 CD per M. The selection criteria was such that we had taken only phaco patients, not SICS patients, those with 40 to 82 years, because we wanted to have just uncomplicated surgeries, and they say as we get older, the contrast reduces. And the exclusion criteria was basically anything that will have some impact on the final vision. So decentered lenses, subluxated lenses, more astigmatism, high ametropias, none of them were taken. And the stats was done by a simple unpaired t-test. And here we were surprised to find that there were more female patients as far as the multifocal group was concerned. When we looked at the age of the monofocal and the multifocal group, the average age of the monofocal group was 62 years, while the multifocal patients were relatively younger, and the p-value was significant. We looked at the distribution of laterality, and of course, more patients of monofocal group were bilateral as compared to more unilateral patients in the monofocal group. We looked at unaided distant visual acuity between monofocal and multifocal patients after the last post-op visit, and we were surprised to find that in the multifocal group, there were more patients who were 6'6" to 6'9" unaided, almost 80% of them, compared to just 48% in the monofocal group. This is, of course, when the A scan was corrected for emetropia. So when we look at the post-op unaided distant vision in decimals, we see that there is a significant difference, and the multifocal patients are doing much better than the monofocal patients. When we looked at the near visual acuity between monofocal and multifocal, there is a huge difference. In almost 64% of multifocal patients are N6 without any specs, unlike 0 in the multifocal group. Of course, when we looked at aided distant vision, there is no difference between monofocal and multifocal. When we look at aided near vision between monofocal and multifocal, again there is no difference, but in multifocal, a lot of unaided N6 is there. But we were surprised that when we compared contrast sensitivity between monofocal and multifocal group at the 3-month visit, we found that there was absolutely no difference. And the normal range of contrast sensitivity of a human eye is 1.2 to 1.35 under photopic conditions at distance of 1 meter. And so here we found that there was absolutely no difference in the 2 groups. So the study proved that in the multifocal group, the unaided vision was better for near and for distance. And this was similar to results from JAVIT, which was a classical study published in ophthalmology more than a decade ago, where 38% of multifocal patients did not wear specs as compared to 10% of monofocal patients. And in addition, there also 85% of multifocal IOLs did not wear specs for distance compared to 52% in monofocal lenses. So our study kind of mirrored these results. A study showed that higher number of females are interested in multifocal implants. Multifocal patients have more spectacle independence than monofocal patients. Younger age patients wanted perhaps spectacle independence, and they were willing and perhaps able to pay more. And there is a study in the British Journal which says that the multifocal effect is probably better appreciated by younger patients. But the surprising thing was there was no difference in contrast. There was no significant difference in contrast between the monofocal and multifocal group after 3 months after phaco surgery. And it's similar to results that have been found again in ophthalmology, where when the luminance is decreased, the near contrast decreases in all spatial frequencies in both groups. So this is similar to what was done in us. So in conclusion, There is no significant difference in both the groups in photopic conditions after 3 months. And the multifocal IOL patients have a higher rate of spectacle independency as compared to the monofocal patients. Only small limitation that this we had checked in photopic conditions, so we ideally should do it later in mesopic condition. And we should also consider pupil size while doing contrast sensitivity testing. And perhaps this needs a more bigger study. Thank you.
The spectacle independence, since you had done surgery in one eye only. So, in one eye only. The surgery was done in one eye and then compared with from monofocal to multifocal.
Yes, sir. But there in the multifocal group also only 40% were both eyes cataract surgery. There were similarly unilateral patients also in the multifocal group. It's not that all the multifocals were bilateral. So, and they were more happy. I mean, they said they could manage without specs.
So in case we aim for a monofocal vision, wherein you make a little myopic one eye, the other eye you make emmetropic, then if we compare, then perhaps the spectacle limit.
Yes, sir. We would need a larger study to do that comparison. Thank you, sir.
And the next speaker, Dr. Neeraj Agrawal. I invite you to present your paper.
Following this, we have Dr. Ashwini Kumar. Is Dr. Ashwini Kumar there from Patna? Dr. Ashwini Kumar. If he's not there, then the next speaker is Dr. Shroff.
Yes, sir.
You are there. Okay, thank you.